Hello. Great. Welcome, everyone. This is Robin Riddle with the Information and Referral Center at Stanford's Movement Disorder Center, and also the CEO of Brain Support Network, an atypical Parkinsonism-focused nonprofit. Most importantly for today, I'm your host and moderator for this event. Stanford is pleased to offer this inaugural webinar for our occasional series on Parkinson's and atypical Parkinsonism disorders. We're recording today's event and uploading it to YouTube at some point soon, so we hope you'll pass the recording along to others who may be interested. And we will be sending you an email after the event, so watch for the link. Today's webinar is focused on progressive supranuclear palsy. The diagnostic criteria for PSP was very recently changed, and that's what led us to thinking about having this webinar. Today's speaker will discuss that criteria, and she will be providing an overview of the two most common types of PSP, and I think she might even be providing an overview of a third very rare type. So we are going to be looking at these topics today. How is PSP diagnosed? How many years does the average person wait for a diagnosis? The two main types, as I mentioned, what's the new diagnostic criteria? And we're going to focus on probable PSP. And what's the accuracy of a PSP diagnosis? Today's speaker for these topics is Dr. Kathleen Poston. She's a movement disorder specialist here at Stanford University in the neurology department. She conducts research focused on neuroimaging biomarkers, and she'll be talking a little bit about imaging in the talk today. She's also the co-investigator of the Udall Center of Excellence for Parkinson's Disease Research. We will plan on holding a question and answer session at the end of Dr. Poston's talk. Throughout the presentation, we'll hope you submit questions through the question and answer button at the top of your screen. You might check that out now. In addition, we have received many questions in advance of today's webinar, and we'll certainly try to address as many of these questions as we can. Dr. Poston will be presenting for about 20 or 25 minutes so that we leave a lot of time for slides. Thank you very much for joining us, Dr. Poston.
Thank you, everyone, for joining. This is Dr. Poston from Stanford, and I also want to thank Robin and the Brain Support Network for hosting this first webinar. We're going to be focusing on the diagnosis of progressive supranuclear palsy today, and particularly paying attention to why the new criteria was developed, how this criteria can be applied in the clinical setting, both from the perspective of the clinician as well as from the perspective of the patient and the patient's families. So first of all, why have there been all these revisions and thoughts about the clinical diagnostic criteria? Well, it turns out PSP can be a very difficult disorder to properly diagnose. The more classic syndrome, which I'm going to speak a little bit about, which is referred to as Richardson syndrome, is probably one of the easier versions of PSP to diagnose. But it turns out when a lot of different studies have looked at patients who were diagnosed with progressive supranuclear palsy during their life, who have gone on to donate their brains for research, when you look at their final autopsy diagnostic confirmation, only about 63% of people who during their life were diagnosed with PSP actually have that diagnosis confirmed on autopsy. That's a pretty low number. We should find ways to do much better than that. And this has very significant consequences, not only for obviously patients and for patients' families, but also for clinical trials. And I'm going to talk a little bit about that a little bit later when we talk about the new diagnostic criteria and what it can be used for. But just to sort of set the stage, you can imagine if you were recruiting patients into a clinical trial trying to find a treatment for a disorder, but only 63% of the people who are in that study actually have the disease you're studying, it would be very hard to find something that actually worked, because almost half of the patients wouldn't even have the disorder that you're trying to address. So there's a big implication here. So let's talk about some of the other things that is oftentimes misdiagnosed as PSP. The biggest group is Parkinsonism. And that is a collection of disorders that includes Parkinson's disease, dementia with Lewy bodies, and then sort of a broader Parkinsonism, which in these autopsy cases means that the clinician thought it was some form of Parkinsonism, but couldn't definitively say it was either Parkinson's disease or dementia with Lewy bodies versus some other Parkinsonian disorder. So over 10% of patients in their life when they are called PSP, in this particular study of 181 patients, were found to have this Parkinsonism. That was the most common thing. And we're going to talk a little bit about distinguishing Parkinsonism from PSP and how to use the criteria. The other most common disorders were less frequent. So cortical basal degeneration, which is oftentimes confused with PSP, was only about 2%. Frontotemporal dementia was about 3%, and Alzheimer's disease was about 4% in this one study. And so obviously we need to find ways to distinguish people who truly have PSP from these and other disorders in order for us to more accurately tell patients what's going on, and also to more accurately enroll people into clinical trials. So let's just take a step back and think a little bit about the PSP clinical features. The motor features of disease include, again, this Parkinsonism, which I spoke earlier. And that really is a syndrome that's defined by axial rigidity, and that means rigidity in the central part of the body, meaning the neck, the trunk, postural instability, so poor balance, bradykinesia, which means slowness of movement, as well as slowness of facial expression muscles, which is often seen as reduced blink rate. And then there's this classic supranuclear gaze palsy. And I'm just going to take a moment to describe what that is, because this is really the hallmark feature. And as you'll see in a few other slides, that this is the thing that most accurately diagnoses people with PSP. So what this means, a supranuclear gaze palsy, is that when we try to take a voluntary eye movement, so we try to quickly look up or look down or quickly look to the right or to the left, that movement is called a saccadic movement. So you're quickly looking in one direction. When you slowly look up or slowly look down, that's a smooth pursuit. And those voluntary eye movements are controlled by the cortex of the brain above the nucleus that is controlling the eye muscles. And that is the part of the eye movements that is most impacted by PSP. Essentially, patients at first have difficulty with the quick movements, so that saccadic movement to quickly look up or down. And then later on, it becomes to the point where patients have difficulty looking up or down at all, even with a smooth pursuit. This is in contrast to a gaze movement that's below the level of the nucleus, so infranuclear, and that is when you actually move the head in one plane, can the eyes move around? And so that part is not affected. The other major motor symptom that's affected is speech and swallowing, which we refer to as dysphagia and dysarthria. The two other big aspects of PSP that are affected are thinking, so cognitive profile, which is referred to as executive dysfunction, and certain aspects of behavior. So apathy is lack of interest in activities, obsessive compulsiveness, as well as some lack of inhibition. And so some patients will be very impulsive in their behaviors. These cognitive and behavioral aspects can sometimes make it very hard to distinguish PSP from other types of memory problems. two of which were on the previous slide were Alzheimer's disease and frontotemporal lobar dementia, which both also can have cognitive and behavioral. So when there's more of these cognitive behavioral aspects, it becomes harder to differentiate PSP from those disorders. When there's more of a motor component, it's harder to distinguish PSP from Parkinson's. So the original diagnostic criteria that have really been used for the last couple of decades were actually developed in 1996. These were based off of a series of autopsy cases, so patients who had been followed throughout their life, and then at the time of autopsy were found to have PSP in their brain. And when they looked back at the clinical symptoms and saw what about the clinical symptoms best distinguished someone who had PSP from other brain disorders, this is what they came up with. And it was pretty good criteria. I mean, these criteria have been used now for a couple of decades. So they did their job at the time, and they really changed the field so that people could make sure they were talking about the same thing. And just to give you a sense of what those criteria were, is that generally the disorder had to be something that was gradually progressive. That distinguishes the symptoms from a stroke, which is something that happens suddenly or suddenly changes over time. So that's an important part. Starting to have the features over the age of 40. In general, people do not have PSP on their final autopsy diagnosis when their symptoms are start under the age of 40. So that was kind of the youngest that had been identified in the autopsy cases at that time. And then this vertical supranuclear gaze palsy plus posture instability with a propensity to fall within the first year of symptoms. So these were the things that seemed to most specifically identify people for PSP. There were a lot of other supporting features, and basically those were just things that tended to differentiate PSP from other disorders, but maybe weren't quite as specific. And some of those I've always touched on, and that's that rigidity, particularly in the neck and trunk, a tendency to fall backwards, which is what we call retrocollis, with the head backwards. Very poor response to the primary medication for Parkinson's disease, which is levodopa, and then some of those cognitive symptoms. But the problem is that these supportive features didn't really do a great job of always distinguishing people who had PSP from other disorders. And this is the criteria that was used for that autopsy study that I showed you in a previous slide. And what has been identified over the last 15 years is that most patients eventually would have the classic parts of the syndrome, which is that supranuclear gaze palsy and the tendency to fall. But turns out a lot of patients didn't have those particular features early on in the disorder. And what this slide is meant to show you is that there were a lot of patients who, this is time along the x-axis, and early on in the symptoms, when disease severity is very low, a lot of patients did not necessarily have those eye movement abnormalities, and a lot of patients didn't have the falling. And so it was very, very hard to diagnose someone with PSP. As time goes on in their life, those symptoms tended to emerge, and they would develop what was called the classic Richardson syndrome, which is the one that I described to you. But this would sometimes take many, many years. And in fact, some people would die before they even developed the full Richardson syndrome. And so at the time of their death, for instance, here, they wouldn't even have those eye movement abnormalities, or they might not have any of the severe falling. And so how on earth are you supposed to diagnose somebody who, even at the time of their death, doesn't have the primary cardinal features of the disorder? But of course, we want to understand those patients, and we want them to be able to receive the right treatments. So this is why it takes many years sometimes for people to get the right diagnosis. If patients had the classic features early on, meaning the falling very early, along with the eye movements very early, then sometimes it would only take maybe a year or two before they'd get the right diagnosis. But many patients who don't have those features until 4, 5, 6, 7, 8 years into the disease, they would not get the diagnosis of PSP because they didn't have those classic features so early. So this is what leads to the finding that a lot of patients who eventually have a diagnosis of PSP, they can have symptoms for, up to 6 or 7 years, sometimes even before they get the right diagnosis. And so this can really lead to obviously a lot of distress amongst the patients and families, as well as a lot of frustration in doing clinical trials because we're not enrolling the right people. So what this slide here shows is that when we actually look at who has the pathology of PSP on autopsy, that's on this the left-hand side of your screen, the different types of clinical syndromes. This top one up here is what I keep referring to, this Richardson syndrome. This is the people who have that classic eye movement abnormalities as well as that early falls, so a propensity to fall and maybe even some actual falls within the very first year of their symptoms. That's the Richardson syndrome. Turns out the people who had those two features, the eye movement abnormalities and the early falls, almost every single one of them, when they went to autopsy, actually had PSP. So those are the people who got the diagnosis the earliest and was the most accurate. The folks who had more of a Parkinsonian picture, so maybe they had some slowness and stiffness and some very subtle eye abnormalities, but maybe they didn't have any falls in the first 3-4 years, or maybe the eye abnormalities were very mild and were hard to pick up on a basic neurological exam. Those people, while a lot of them were correctly diagnosed, a lot of people were not correctly diagnosed on the left-hand side of the screen. Similarly, the third syndrome that I'm going to be talking about is this PSP primary freezing of gait. These are folks who, again, on pathology have typical PSP pathology, but their main symptom is actually difficulty initiating walking very early on. So I didn't mention that before, did I? That wasn't part of the classic Richardson syndrome. It was more of the falls, but this is more of a gait disorder. So these folks have also been very hard to diagnose in the past. I'm going to focus on these top 3 syndromes since these really account for about 90% of people who have PSP on pathology. But it is important to note that there are some of these other syndromes that are mentioned down here on the bottom of the page, the cortical basal syndrome, the non-fluent primary progressive aphasia, the behavioral variant FTD, and cerebellar ataxia. These are a very small percentage of people with PSP, but they do exist, and it's important to understand that, and that is part of the logic behind the somewhat complex nature of the new diagnostic criteria. So let's just focus on these 3 at the top. So as I mentioned, PSP, Richardson syndrome, is the most common clinical variant, and these people, if they have this clinical syndrome, they are very, very high likelihood to have actual PSP pathology at the time of autopsy. So this one gives us the best prediction of what the underlying pathology is. So as I mentioned, these unexplained falls, unsteady gait, and slowness really are one of the hallmark features of the syndrome. I mentioned the personality changes, the lack of interest in activities, which is what we call apathy, and this loss of inhibition. There can be some executive dysfunction. So those of you who aren't familiar with what executive dysfunction means, this is a type of cognitive thinking that involves problem solving, switching what you're thinking about quickly, being able to organize your day, kind of a lot of those cognitive processes that we do a little bit automatically, but can be very difficult for people with PSP. If you ask them simply to, get their things together so that you can leave the house, they might have a hard time organizing what needs to happen first in order for them to get ready to go out the door in the morning. There are these speech changes that are very classic, where slow speech with very soft tone, this difficulty of swallowing, which we call dysphagia. And then again, these classic eye movements. But even in these patients with the classic Richardson syndrome, some of them might not get those eye movement abnormalities for the first 3 or 4 years. Early on, what they might see is just decreased velocity of the movement, decreased amplitude of the movement, meaning that they can't look all the way up or all the way down, or absent or decreased optokinetic nystagmus. So for those physicians who are out there who are wondering, well, how on earth am I supposed to actually test optokinetic nystagmus in my exam? I don't carry around an OKN strip like I did as a medical student. The good news is that there are some wonderful apps on both Android and iPhone that will actually pull up a classic OKN strip. So you don't need one of the actual strips anymore. You can just download an app and use it right there in your office. And I've completely converted over, and I just use my iPhone app now. And it's actually quite simple. So you don't need to have the tools. You just need to have a phone, and you can check this in your office pretty simply. So this PSP Parkinsonism is the one that has the most difficulty distinguishing between PSP and Parkinson's disease, or PSP and dementia with Lewy bodies. This subtype was really identified in the last 10 years, so fairly recently, relatively speaking. And this was identified based on an autopsy study out of the UK, where they looked at a bunch of patients who had donated their brain and had PSP on autopsy, but did not have the diagnosis of PSP during their life. And when they looked back at the clinical features that had been documented within the charts, they found that a lot of those patients had features that were very similar to classic Parkinson's disease, particularly early on. A lot of times we think that PSP should be very symmetric without a lot of tremor. Well, it turns out these folks had a lot of asymmetry and a lot of tremor, and a good number of them had some early response to levodopa. Now, as the years progressed, that response to levodopa went away, and oftentimes that asymmetry became quite symmetric. But it really resembled some classic idiopathic Parkinson's disease early on. And this really identified a problem, because this meant that early in Parkinson's disease or early in PSP, some patients are difficult to distinguish. Now, it was uncommon for these people with PSP Parkinsonism to develop the classic levodopa-induced dyskinesias. They didn't have a lot of autonomic dysfunction, meaning they didn't have a lot of the blood pressure drops that are common in Parkinson's disease. They didn't have that many visual hallucinations, and that's really important because that's the key feature that distinguishes PSP from dementia with Lewy bodies. Dementia with Lewy bodies is a variant or a complement disorder to Parkinson's disease, where the visual hallucinations are one of the distinguishing features. And so these PSP Parkinsonism patients did not tend to have the visual hallucinations. So that's a really important question to ask in differentiating PSP Parkinsonism from dementia with Lewy bodies. The third syndrome, and again, this one's not as common, but I think it's important to recognize, is this pure akinesia with gait freezing. This is a syndrome where really it's an isolated gait disorder, where patients just primarily have difficulty initiating walking, where their feet just really stick to the floor. And this can happen for years, sometimes up to 5 or 6 years before the development of any other PSP features, meaning their eye movements are completely normal during those first 5 or 6 years. This can really lead to a lot of diagnostic confusion. In addition to freezing of gait, sometimes these patients might have difficulty initiating speech or writing, but oftentimes they don't have tremor, rigidity, any cognitive problems, or eye problems during the first 5 years. This one's a real tough one to diagnose, but it's important that this has now been recognized as a variant of PSP, as almost all of these patients do eventually go to have PSP pathology at autopsy. So let's move on from there and look at our new diagnostic criteria, which was just published a few months ago. And the key features, again, sporadic occurrence. This is important to distinguish it, again, from people who have a stroke in certain places in the brain, which could easily resemble PSP. They stuck with the age 40 or older at onset, because continued autopsy studies really tended to show that it's very, very unlikely for someone to start their symptoms under the age of 40. This gradual progression of one of the PSP-related symptoms. And again, the core features are the ocular motor dysfunction, the postural instability, the akinesia, which again is a lack of movement, and cognitive dysfunction. Now, on the next slide, I'm going to show you a very complicated grid Oh, sorry, we'll get there in just a second. Let's take a step back and talk about what the word probable PSP means. So part of this new definition is that they again reestablished that we cannot say that somebody has definite PSP without the autopsy findings. It's just not possible at this point, based on our clinical exam, brain imaging, blood tests, or anything, to 100% say someone has definite PSP. So that's not possible, unfortunately, until autopsy. A lot of research is going in to improve that, but that's just where we are right now. So the best we can do during life is probable PSP. What this distinction means is that it's highly specific. If somebody meets the criteria for probable PSP, there's a very, very high chance that the underlying pathological diagnosis will be PSP. So these are the people we're the most certain about. Unfortunately, this is good for clinical trials where you only want to enroll people who have the real underlying pathology, but it is not very sensitive. And if you actually apply the probable diagnosis to most people with the clinical diagnosis of PSP, most people who have the final PSP pathology do not fully meet the probable criteria. So this means that if you don't have probable PSP based on criteria, there's still a really, really good chance that you have PSP, and that's really important to understand. This criteria was really put forth to enhance our ability to do clinical trials, to make sure that if I'm doing a clinical trial to try to target a very specific part of the PSP pathology to slow the disease down or to treat symptoms, that I only have people in my study who actually have PSP. If we don't do this, then we will pretty much never be able to accurately to really accurately diagnose and eventually come up with good treatments. So that's what probable means. But unfortunately, that means that most people do not fit this criteria. Okay, so now on to my very difficult to understand slide. So this is the grid that was put out with the new diagnostic criteria. Looks pretty complicated, but I'm going to break it down for you in a way that's actually quite easy to digest. So there are 4 different categories: ocular motor, and that just means eye movement abnormalities; postural instability, so that's difficulty with balance when walking; akinesia, which refers to as the general slowness of movement; and then the cognitive dysfunction. So in order to have probable PSP, you have to have 1 or 2 plus this or that. Let's just look at the grid, and it's a lot easier to understand there. So for the classic PSP Richardson syndrome, you have to have either a vertical supranuclear gaze palsy, so that means complete lack of movements in the vertical direction when spontaneously trying to look up or down, or slow velocity and vertical saccades. So this is just that slowing of those movements, and this can be picked up on that OKN test. So one of those 2 things. You don't have to have the full supranuclear gaze palsy. You can just have the slowing of saccades. But you have to have one of those 2. Plus, you have to either have repeated unprovoked falls within 3 years, so they loosen this up. The original criteria said 1 year, it's now within 3 years, or a tendency to fall on the pull test within 3 years. So this is that test that the doctor does where they give a sharp tug on the shoulders backwards, and most people should be able to catch their balance in 1 or 2 steps. If somebody takes more than 2 steps or has difficulty regaining their balance, that's what we would find on exam. So this is what is required for the probable diagnosis of PSP Richardson syndrome. For the probable diagnosis of PSP Parkinsonism, again, both of the eye abnormality categories are there, but now instead of that tendency to fall, patients have the slow, stiff Parkinsonian syndrome, which is important, can either be levodopa resistant or can sometimes have an early response to levodopa. But the key is to be really confident about the diagnosis. This eye movement abnormalities have to be there, because if those aren't there, this syndrome over here would be very difficult to distinguish from classic Parkinson's disease. And then for the PSP primary gait freezing, Again, you have to have the eye movement abnormalities plus a progressive gait freezing disorder within the first 3 years. So as you can see, the key element to all three of these probable diagnoses is really the vertical supranuclear gaze palsy, because this is the most specific finding for PSP. This finding simply doesn't happen in disorders like Parkinson's disease or Alzheimer's disease or some of those other disorders that I mentioned on the first slide. But as I mentioned as well, there are a lot of patients who don't have these eye findings in the first couple of years. So just because you don't have the eye findings doesn't mean you don't have PSP. It just means we can't be as confident about it. So I'm just going to show a quick picture here of some supporting features with the MRI scan. But again, similar to the eye movement abnormalities, when we see this on our scan, it's super helpful because this is pretty classic for PSP, but most patients do not have either of these findings. This top one is called the hummingbird sign. This is the midbrain, and this is the pons. And usually the midbrain is a little bit thicker than this. And as you can see, when it's nice and thinned out like this, it resembles a hummingbird. And this picture is what we oftentimes see in PSP. But again, most patients with PSP don't have this. So it's helpful when it's there, but if it's not there, it doesn't really tell us anything. This is the morning glory sign, or the Mickey Mouse ears, it's also referred to as. And again, this shows the thinning of this part right here in the midbrain. And this, again, it's helpful when we see it, but if it's not there, it doesn't tell us anything. So finally, just a picture of what the PSP pathology looks like. Here we have the tau is the primary abnormal protein. So tau is a normal protein in the brain. It does lots of very important things, but when it comes into these little neurofibrillary tangles that look like this under pathology, and specifically when you get these glial tau tufted astrocytes in the gray matter, this is exactly what our pathologists see under the microscope, which tells them the final definitive diagnosis of PSP. So I hope that this has been helpful in explaining what some of these new criteria are and how we specifically use them. This is just our overall movement disorders center here at Stanford. As you can see, we have a ton of people, all of whom have specialty in movement disorders. And now I'm going to pass this over to Robin, and we're going to go with some questions.